Hi, everyone. I'm Angel Qin. I'm a thoracic medical oncologist, University of Michigan.
I'm Tom Stinchcombe, a thoracic medical oncologist at Duke.
And we are ready for your questions, so put them in the chat. Do we know which ones are the ones in the bottom? Mm-hmm. Okay. So we have a question about bone metastases, doing well on alectinib. Should they continue to take the Xgeva once every 3 months? Can they stop taking the Xgeva, and how long should they take it? So I think that's a phenomenal question. This actually came up in a patient of mine who had been doing well on a TKI for, gosh, I think 5 years. And at this point, we were more worried about some of the side effects that can be related to long-term use of these bone modifying agents, and because they were doing incredibly well, I actually talked with their endocrinologist, and we actually mutually agreed to do it actually just once a year, more like an osteoporosis dosing rather than a bone metastases dosing. But I feel that if you're doing well, you probably, especially for several years, you probably don't have to continue an Xgeva.
I would agree with that. I tend to not use Xgeva because I think the best thing is the high response rate will lead to healing of the bone and sclerosis. And I think the complications of Xgeva, whether they be dental and other problems, can impact your quality of life. So I'd have a conversation with you, but I'd be inclined to discontinue it.
I think we have a question about any ways to predict who might be more apt to get radiation necrosis from gamma knife of a brain lesion. That is a phenomenal question. I think thankfully radiation-induced necrosis is still fairly rare from what I've seen, but I don't really know that we have a really great predictor. I don't know.
I don't think we have a great predictor, and this is a very hard diagnosis. And I think this is one of the reasons why when we talk to patients, we really sort of emphasize TKI up front if you're small and asymptomatic brain lesions to avoid this potential side effect. And I think as patients are living longer, we're actually seeing probably more radiation necrosis 1-2 years out, that maybe, and so it's something that needs to be considered carefully. And we have a team of radiation oncologists, and we'll often see them together.
Mm-hmm. Yeah. So the question to me about what are the initial results from the gilteritinib study? So it's still pretty early. I'm really incredibly thankful for support from ALK Positive, from Astellas. I think we only have about 9 patients who've been on this study. We've certainly had kind of a spectrum. Some patients have benefited, others have not. But I think it's a little too early to really know, truly how effective gilteritinib is and for which patients. I will say the only thing that I found to be really positive from the study so far, though, is of the 9 patients, we haven't really had any significant side effects where we either had to hold the drug, made it really difficult for the patients to tolerate. Most patients have tolerated quite well, so I think that's really great, especially from our talk earlier about toxicity and safety.
I'll take the next question. Someone was started on alectinib, and would it be wise to switch to lorlatinib? I think it's hard to answer this question. I think if someone's been on alectinib and had good disease control and tolerance for several years, I'll be inclined to start alectinib. I think if someone shows up de novo, I think lorlatinib is my preferred agent. We have a discussion, shared decision-making, but I think if it's been within a month or two, I would have a conversation about switching to lorlatinib.
Yeah, I agree. I think especially there might be some characteristics, especially, for example, someone had brain metastases. I would definitely try to discuss with them a switch to lorlatinib rather than staying on alectinib. If diagnosed 4 years ago at stage 2B, NED after surgery and chemo, amazing. Is there any need to consider starting alectinib? I would personally say no. I think it was 4 years ago. We know that the ALENA study or adjuvant alectinib was really done in patients immediately after surgery. We know that there's definitely a chance that the cancer is cured, after surgery and chemotherapy. It's been 4 years. So I personally would not start alectinib in this situation.
I would not start alectinib, and the one this is an evidence-based medicine. I concede this up front. But I would probably follow you longer because I think we've seen some of the ALK patients who underwent surgical resection are recurring at years 5 and 6. So don't, historically at 5 years you were sort of cured and you divorced your oncologist and you went someplace else. But in the modern era, we still want to see you.
Don't divorce your oncologist. You want to do the next one?
Okay, sure. Looking at the next one, the patients have been on 3.5 years of alectinib, paused for 2 weeks, then it sounds like they had some adverse events. Then was given the choice of 450 or 300 BID or loratinib. This is a difficult conversation. I think we would probably sit down with you. I think importantly, alectinib, the 450 BID, I have confidence that that's an effective dose as 350 BID. But this would be, if I got this from a referring physician, I would probably say, hey, I have to see this patient in person and have a conversation with them.
Yeah, I mean, I think, I guess what I always tell my patients is I really hate to give up on a drug unless I know for sure it's not working. I anecdotally do have a few patients that are on 300 because of side effects, and they have been doing well. But I agree, this is a tough choice, right? Do you give up on the alectinib if it's been effective, and try to switch it to lorlatinib, which is not without its own baggage, so to speak, or do you try to go down 300? I think it's definitely worth the conversation, but I guess my initial gut feelings at least have a discussion of going down the dose before we truly give up on the drug. Let's see.
They're coming in faster than we can keep up.
Thoughts on reducing blood thinners after 6 months with clots that cleared and no heart issues? Ooh, that's a great question. This is a really challenging question. I mean, we know that there are risks with long-term blood thinners, right? Bleeding risk is obviously what we worry about, but we also know that patients with cancer do have a higher risk for getting these recurrent blood clots. I feel 6 months. I don't know that I have any evidence, but I feel like that's kind of short.
I'd be inclined to keep it on full dose unless there are bleeding complications. And then I think if this comes up, we do refer to hematology sometimes to really say, is this lifelong or not? And then I want to sort of skip to the next one, which the person has been 80 years old and been through multiple TKIs as well as chemotherapy and with disease progression. I think this is a person that, if they can make it to your trial, would be very well suited. There's also Nuvalent, which I think is, the trial's closed, but they're opening expanded access sites, and I think that would be the next step if they want to pursue therapy.
Yeah, and I would also say that it depends on how this progression of the liver has occurred. Sometimes you can do more liver-directed therapy, right? So especially if it's one lesion, relatively small, they can radiation, ablation, different things they can get, and maybe continue on the Pemetrux if they've been doing well. Patient with 5 brain mets that were treated before ALK confirmation, just starting alectinib 2 weeks ago. Should they switch to lorlatinib? I think, again, with the brain metastases, I think if this patient is fit and I don't have concerns about, other medical problems, I probably would try to switch them over to lorlatinib, especially with the 5 areas that had to be treated.
I would favor loratinib too in this, unless there's a contraindication or something. The next one regards surveillance. I think the CT scan is sort of the working test that we have at this point. It has its flaws. I think with people with bone disease or a disease I've had a couple times with the CT scans underestimated the bone disease, and so I will periodically get PET scans every 6 months or 12 months on those patients, just because I think some people seem to have bone predominant disease.
Yeah, I don't know that CT contrast is necessarily worse than the PET contrast. I will say, though, the reason many of us recommend CT is actually CT is a much more sensitive measure of size, right? And when we're trying to see if you're responding to the treatment. We really want to know if it's gone from the 15 millimeters to 14 to 13, right? And a PET scan, it's a very pretty picture. Things glow, but like, how do you measure glow, right? Do you measure to the outer edge of the glow, inner edge of the glow? And so that's why I don't love PETs. But I mean, to Dr. Stinchcombe's point, there are certain areas, especially like the bones, where it's kind of hard to tell in a CT. So I think the more complementary, but CT is what I usually start with. And the next question is about surgery and delay in surgical recovery while on a TKI. I think this comes up quite a bit. We have our surgeons asking us to provide clearance. I think mechanistically, I don't think that there's much impairment in terms of surgery, impairment of healing from surgery from something like alectinib. It's not like the EGFR, where maybe theoretically the target that you're hitting might affect wound delay. It also, I think, depends on how invasive the surgery is. If it's a really big surgery, right, something hopefully as a knee replacement should be fairly minimally invasive versus like an open heart surgery, right? So I don't, I usually ask patients to hold it for surgery, but once they're out of surgery, I ask them to get back on it, but I don't know that I'm basing that on much evidence.
No. I would agree, and I don't like long treatment interruptions, and there's no evidence it impacts wound healing. The next question is, I think, a fascinating one that we see every day in our clinic. A person's been on alectinib. It sounds like they have sort of local regional recurrence that is sort of low volume disease at this point. And the question is, what's the next steps? And for this patient, I would probably get a tumor biopsy and first to do some genomic testing, see if we can identify the mechanisms of resistance. Then make sure that they're staged with a PET scan and MRI. And I think we'd look to do local therapy. However, if I see a resistance mutation to alectinib, then I'm a little bit more inclined to switch to lorlatinib at that point and not just rely on local therapy followed by alectinib. But this is another one. If I got called from an outside physician, I'd probably say, like, I think I need to see this person in person.
Absolutely. Are there two sets of questions going on?
You can tell them to add to the chat. But it's
I see. Okay, fair enough. Oh, goodness. So I guess then I'll take one from the other side. So someone's asking if one can switch back to alectinib if lorlatinib has had too many side effects. And I think this is really depending on the context in which lorlatinib was switched. So if someone just got started on alectinib, but because of the Crown data decide to switch to lorlatinib, then absolutely I think they should definitely go back to alectinib if lorlatinib truly is not tolerated. But obviously if you were switched to lorlatinib because you had progression on alectinib, then I don't think you can switch back.
All right. So which list should I go from?
Either one.
Okay. So there's two lists. I'm going to look at it's a question about a person with a brain metastasis and they're unable to do a biopsy. And thoughts on a lumbar puncture. I wouldn't do that unless I thought that there was concern for leptomeningeal disease or something else at this point. I think the yield from one lumbar puncture is very low, and so I don't think that's going to be fruitful in terms of getting cytology or other aspects. So I would advise against that.
Yeah, agree. Someone's asking about patients doing well 10 years plus on stage 4 ALK, but had depression in the brain, and then developed leptomeningeal disease. Third generation TKI resolved it. Can leptomeningeal disease recur, and does NVL-655 fight LMD? So leptomeningeal disease, or LMD, is quite tricky. Just medically, we think about it affecting not just concrete or discrete brain metastases. It's more like the lining that surrounds your brain and your spine getting affected. I know that NVL-655 does, on the presentation that Dr. Lin shared earlier, does have intracranial effects, and theoretically, if we can get a higher enough dose into the central nervous system, you might see efficacy of that drug against LMD, but I don't know that this is something that NVL-655 has specifically been evaluated for.
Next one is a person who underwent surgical. Could you back that down? Sorry about that. If not, I could just go to the next one. The person who underwent surgical resection, then after that had, it looks like, radiographic reappearance and started on alectinib and no evidence of disease. I think at this point, and their PET scan is negative, and the question is about consolidation therapy. I mean, I think we frequently have people see radiation oncologists, but generally I would not recommend it at this time because I don't think that it's going to provide a great deal of benefit.
Yeah, I agree. A patient with stage 4 ALK cancer on alectinib for 3 years, feeling great, just an elevated bilirubin. Would you consider switching TKI? And they're doing really great. I think it depends on how elevated the bilirubin is. I will say that elevated bilirubin is definitely a side effect of the alectinib, but the majority of patients are asymptomatic from it. It doesn't affect them. It doesn't affect their liver function. I more think about as alectinib just like chronically kind of irritating your liver a little bit. So I think if it's more of a number and you're doing really well on alectinib, I wouldn't switch to lorlatinib because all of our TKIs can have liver toxicity. So I don't think that just because you switch TKIs that you're going to get rid of this liver toxicity per se.
I wouldn't switch either. Next one was therapies to sort of combat the fatigue associated with TKIs, in this case, alectinib. This can be hard. I think we generally prescribe exercise, good sleep habits, and then occasionally we've used Ritalin, but Ritalin or methylphenidate's the generic name. But I think this can be hard to combat the fatigue, I think, at this point. I've not had tremendous success with methylphenidate, in terms of combating fatigue.
Yeah, I think I always tell my patients fatigue is the hardest one. I wish I had a magic pill that would help, fatigue. I would like that magic pill actually. But, it is a really hard, and I think it's because something like lorlatinib or even alectinib, they have CNS activity. So you are going to experience that in the form of fatigue. But I think something that, Dr. Stinchcombe mentioned was physical activity. That is super important. I think, when you don't feel well, you just feel like you don't want to do anything. You kind of want to be more of a couch potato, but that actually just makes you feel worse. So keeping physically active, playing sports, going out, doing yoga, all those things are really, really important to maintain, actually can help combat the fatigue. See, this question says, when do you choose not to do local consolidative therapy after 8 weeks of lorlatinib as first TKI? Do you think it's better to do something more? I think we kind of discussed that this morning about like the perfect timing for LCT, and we just don't have a perfect timing. My kind of own practice has been to see how well a patient can do on the TKI. It's 8 weeks of lorlatinib is fairly short. We can continue to see some good response even months in. So I kind of really wait for the scan to show, truly no more response. And at that point, think about whether something like LCT makes sense. I probably wouldn't do it right off the bat after 8 weeks of lorlatinib. I probably want to give it a little bit more of a chance.
I think you need at least 6 months to really assess how well the drug's going to be tolerated and how effective it is. So I think that 8 weeks is a little premature for me. The next one is a patient with stage 4 on alectinib, doing well. Then it looks like there is a rise in a blood-based test at this point, but radiographically it is stable. What to do to continue with the current therapy or change? I would advocate for continuing the current therapy at this point because clinically you're doing well. Radiographically, you seem to be doing well, and you could argue for maybe closer surveillance at this point, but I don't think that's strong enough evidence to suggest you should change therapies. And the reality is we only have a couple therapies, and you don't want to, like Angel said, you don't want to give up prematurely on an effective therapy.
Yeah. Let's see. For screening, what is a better test, CEA in blood or cfDNA, cell-free DNA? I'm not sure maybe what the screening is referring to. If there's lung cancer screening, we certainly don't have, unfortunately, a good blood-based marker to do lung cancer screening, whether it's CEA or cell-free DNA. Both are quite non-specific. And as we mentioned this morning in the panel, we don't actually have a good blood-based marker for lung cancer, even when we know you have lung cancer. We don't have a good way of measuring it. So I, for screening purposes, I would, if there's a risk for lung cancer, it's a low dose CT. That is our current recommendation for screening.
It's also possible they're talking about surveillance. I'm not sure about you, but I don't do surveillance CEAs or cell-free DNAs at this time. I will if there's something that's concerning on the imaging at that point, or clinically symptomatically, but I don't do surveillance blood work.
Yeah, agree.
Where are we on the questions?
I think we're on maybe the bottom. Or no. Nope.
So the questions are coming in so fast that we're losing track of which ones we've answered. Let's see here. Here's a question: why aren't drug concentration screening assays more available to help management of side effects? And I think this is a great question, and I think one of the things that we would like to see some clinically validated tests there, particularly when patients are having side effects or other things to do this. I know that sometimes there can be different chemotherapies will have it, but I think this is one of the innovations that we need to do. I think.
Yeah. Someone's been unelected for 16 months. They have some ground glass opacities in the lungs that have been shown on the past 2 scans. Should they be worried about pneumonitis? And should they be concerned about long-term lung damage? However, they're actually feeling much better since starting the TKI, so not really sure if they're symptomatic. I think this is a really good question. We see this comes up a lot. Patients, we have lung cancer, we certainly don't want them to have another injury to the lung, but I will say that in patients who are on TKIs or even immunotherapy or chemo, they can have these more inflammatory things come up on a scan that look like ground glass opacities, and that they may be asymptomatic. And so pneumonitis doesn't really have like a strict definition that I'm aware of, but I think we'd be more worried about the imaging findings if the person was symptomatic. But if they're actually feeling better since starting the TKI, I would just probably keep a close eye on those ground glass opacities, make sure they're not getting worse, making sure that functionally, getting pulmonary function tests or oxygen saturation, that the numbers look as good as the patient feel. But I would not switch up from alectinib just because of that. And I don't know that these ground glass opacities are really a predictor for more long-term lung damage. Again, I think it's more the symptoms that patients experience.
This is actually, I think, a really important question clinically, because both of us have tried to put people on clinical trials, and there's some vague diagnosis of pneumonitis 2 or 3 years ago, and they're excluded. And so I'm very hesitant to give someone the diagnosis of pneumonitis unless there's, good attribution, because I worry about the future treatment options and implications down the road. Sometimes we will get these people into pulmonary medicine who look there, and what they're going to do is make sure it's not a potential infectious cause that we're missing.
Yeah. Let's see. What do you think about chemotherapy for LCT? I think that's certainly an area of interest, but I don't know that I would think about chemo as a localized consolidative therapy, right? I think, unlike something like radiation or even surgery where it's like you can just do and it's done, chemo, you often would like to give it some cycles, so I don't think about it as local consolidative therapy. I think sometimes you think about it if maybe you're seeing maybe a couple of sites that are perhaps starting to not behave, if you will, and you can think about, well, if I add some chemo, can I suppress those more, misbehaving cell groups and then keep a patient on the TKI? But I don't think about that as true, like, local consolidative therapy.
So look at this one. for metastatic tumor in the pleural space, why aren't directed lorlatinib therapies to the pleural space? And this is a good question. I think we think that the penetration of lorlatinib is sufficient, that just a systemic therapy would be enough to improve this. I think that this brings up an important clinical issue in that not every pleural effusion is malignant. Some people have trapped lung, some people have other things, which is where the lung doesn't fully expand, so there's a space and the fluid keeps coming back, or some people may have an endobronchial lesion that needs to be addressed. So I think just a word to wise that not every pleural effusion is cancer related, and you really need to be evaluated for those other causes.
Okay. One more question. So a stage 4 patient on brigatinib after they did not tolerate alectinib well, feeling great, but liver didn't seem to like the brigatinib. How effective are other things like milk thistle, vitamins, natural remedies to keep the liver function healthy? I think this is a really great question. This gets asked a lot, and I think, you know, we talked about this a little bit too. This is where having a pharmacist is really helpful to look at these drug-drug interactions. I will say there's some vitamins and remedies that are marketed as liver healthy or actually more liver toxic. I've seen a lot of these like mushroom supplements that are actually, I've had a couple of patients actually have fluoride liver failure because of it. So my usual take on liver health is please consult with your pharmacist first before taking it, because you might actually be doing yourself a disservice by taking them.
I've had a similar experience, like someone was doing really well, then their liver test went very high. I was puzzled, and then she told me, well, I've been taking phenylbizol. And so if you do take these, please share them with us, and I'll probably ask my pharmacist, because I think.
Perfect. Thank you all.